Welcome to the Anxious Child Podcast, the podcast that helps you best work with anxious kids and teens. Now, here's your host, Stephen Quinlan.
Hey everybody, welcome to the show. I'm very excited to announce that today we are lucky enough to have Dr. Michael Stein joining us. Dr. Stein is a licensed clinical psychologist in Denver who specializes in adults and teens with anxiety and OCD. He founded Anxiety Solutions in 2010, which was initially a solo practice and has now kind of blown up into a group practice in both Colorado and Nevada. He has written a blog for the Psychology Today website called Understanding the Anxious Mind. He also writes for the Anxiety and Depression Association of America. He's been featured in the Washington Post, HuffPost, Denver Post, Bustle, Psych Central, and other publications. Michael really values effectiveness, integrity, and service. He got into psychology based on these core values, which really comes across in his interview today. I think you'll find that not only is he very knowledgeable on anxiety and OCD in general, but he has a very down-to-earth, almost kind of no-nonsense approach to his work and really values being as effective as possible. He got his doctorate in psychology from the University of Denver. He has founded and served as the president of the International OCD Foundation's Denver affiliate, OCD Colorado. And today on the show, we talk about OCD, the pandemic, anxiety in general, and exposure therapy, and how Dr. Stein puts all of this together and puts it all into practice. So I hope you enjoy this very entertaining and informative interview. One quick note before we get started, if you are trying to get into the Anxious Child private Facebook group, please get in touch with me directly, as we've had some difficulties kind of behind the scenes here making that happen, otherwise known as they locked me out and I can't get back in, at least at this point. So if you have put in a request to join that, I'm not ignoring you, but we just can't do anything about it at this time. However, we are moving forward with our other plans, which I think at this point looks like it should be coming to fruition, hopefully around the beginning part of February. So we'll have that to look forward to. And of course, I will keep you updated around that. So for now, let's enjoy learning all about OCD and anxiety and exposure therapy with Dr. Michael Stein. Enjoy. Thrilled to talk to you. I feel like I know we have different last names, but then I was looking at your picture and thinking we must be related somehow because we have like the same eyebrows, which which are significant ones.
Yes, for sure.
Which
everyone in my family has them.
I was just going to say that, which I've now passed on to everyone to enjoy.
Yeah,
so
you're right.
So tell me, how long have you been in Colorado and kind of when did you start the Anxiety Solutions of Denver?
Yeah, so I've been in Colorado for 16 years, and I started Anxiety Solutions of Denver 11 years ago.
Okay, great.
Yeah, I started it. It was a solo practice initially, and then it's gradually grown into a larger practice in Denver. And then we also have an office in Reno, Nevada now.
I saw that. I was actually going to ask you about that. Are you seeing, because I think you're also seeing people virtually, correct?
Yeah, so we did a little bit of that even before the pandemic because we would get a lot of referrals for people who live in Colorado, but not within driving distance to Denver. And then when the pandemic hit, for the first year, 15 months or something of the pandemic, it was all online. And then since, it's been a lot of people still doing online, even though we're back to offering the in-person option now.
Okay. So you're able to, so it's still confined to people that are in Colorado, right? Just because of licensing requirements and that kind of
Exactly.
thing.
Yeah.
Yeah.
So
Okay.
Colorado and Nevada, because we have people there
And
too,
Nevada. Okay.
and actually California, because one of our therapists in Nevada is licensed in California.
Oh, okay. Okay. So I'd love to get your thoughts on working with anxiety in kids and teens and exposure therapy and how you work with that. But before we get into that, I was just curious your overall thoughts on kind of what's going on right now in the pandemic that we were talking about and how you feel like that has been impacting people's overall anxiety.
Yeah, sure. So I think the biggest thing is just that stress in general is up for
Mhm.
pretty much everybody
Mhm.
since this thing started. And if stress goes up, anxiety goes up, OCD goes up. And so I think we're definitely seeing more anxiety overall, more OCD overall, because of the pandemic. Even aside from just the fear content being related to the pandemic, just stress being up, everybody's mental health, I think, has taken a big hit. And then in terms of more specific content related to the pandemic, certainly, we've had a fair number of people with OCD who have contamination fears about COVID.
Mm.
And so, some people who already had contamination OCD and now it's just kind of about COVID, but even some people who, didn't even display much contamination OCD prior to the pandemic and now are pretty worried about COVID.
Mm. Yeah, and it's tricky too with, and this will kind of I think dovetail into the exposure stuff, but it's tricky too when these fears are they're actual, they make sense. Like they are coming from a place of you do need to take
Yeah.
care of yourself and you do need to be safe. And so there's a legitimacy to that now, which is can be difficult to work with, I think.
Right. Yeah, exactly.
Mm.
It definitely, took some adjustment in terms of like things we would usually do for exposures around contamination OCD. And it's always been with contamination OCD that you do still work within the bounds of, what's reasonable and what is safe. But, I think where that line was during the pandemic definitely shifted.
Mm. Can you explain for somebody who's not familiar what contamination OCD is and what that
Oh
looks like?
yeah, sure. So contamination OCD is the most common type of OCD. So OCD has a lot of different subtypes, and contamination OCD is the stereotypical type of OCD that I think most people think of when they think of OCD, which is like kind of germophobia. So worry about touching various things, various surfaces, the fear of getting contaminated with some sort of bacteria, viruses, disease, other people's bodily fluids.
Mm.
It can be a number of different things. Some people are also afraid of contamination with chemicals and things like that. But yeah, usually it's fear of getting sick, something like that. So
So,
with something like a contagious virus.
so it's like that classic kind of germaphobe that you might see on TV or something like that.
Yeah,
Um,
exactly. And the compulsion is typically a lot of hand washing, a lot of avoidance of touching certain things, especially in public, bringing contaminated things back into the house. And when I say contaminated things, I mean things they perceive to be contaminated,
mhm, mm,
and cleaning surfaces, cleaning objects at home.
mm. It takes me back to kind of the early days of quarantine where I remember we didn't know as much about the virus as we do now. I remember
Yeah.
doing things like wiping down the groceries or the mail
Yep.
because we thought that's what you were supposed to do at that point. Um,
Totally. But back at that time, I said, well, I guess everybody kind of is supposed to have a little bit of contamination OCD
right.
now. And
Yeah.
then we did gradually learn, that touch is not really a way that this thing spreads. But before that, yeah, even I was doing some of the,
Yeah.
wiping down stuff.
Yeah. I mean, it put us all in a way in that place of fear. And at least for me personally, I felt like gave me some empathy around what that must be like to live in a daily way of feeling like you have to do those things and just the inconvenience and energy associated with having to do that
Right.
all the time.
Right. Totally. Yeah.
Yeah, it's really limiting. So let's get into a little bit about your approach in working with anxiety and OCD. I know you do a very specific kind of therapy, which is exposure therapy, which is CBT
Mhm.
based. Can you explain that a little bit and maybe talk about what it is that makes that more effective than other kinds of therapy?
Yeah, absolutely. So yeah, we do what's called exposure therapy. So I'll kind of give you the little explanation that I always give to new clients. So basically, the first most important thing to know about any kind of anxiety or OCD is that anxiety gets kept around in the long term by anything a person does to avoid or fight the anxiety in the short term.
Mm-hmm.
So basically, anything you do when you feel anxious to try and make yourself feel better in that moment, it might sometimes help in that moment when you do it, but it actually guarantees more anxiety the next time you're in a similar situation. So
Mm-hmm.
the key idea is short-term avoidance of anxiety leads to long-term maintenance and increase in anxiety. And the opposite of that is also true. And this is what exposure therapy is based on. The opposite of that is if you purposely do and confront the things that make you anxious in the short term, you eventually get used to those things and they no longer make you anxious in the long term. So, it's basically the process of retraining your brain that the stuff it thinks is dangerous is not actually dangerous, and retraining it through experience that that's the case.
Mhm.
So, I always like to give a very simple example of a dog phobia. Hardly anyone comes in for a dog phobia, by the way, but it's a really...
I've had a couple actually, but yep. Mm-hmm.
Oh, nice. That's good.
Yeah. Yeah.
It's an easy to understand example.
Mm-hmm.
So, if somebody's terrified of a dog and they run away every time they see a dog, that reinforces the anxiety in their brain. Their brain basically learns that they need the anxiety to stay safe, and that they would not have been safe if their brain hadn't rung the alarm bell of anxiety and gotten them to run away from the dog. And so next time they see a dog, their brain rings the alarm even a little more because it really wants to make sure that they stay safe.
Mm-hmm.
And what exposure therapy is it's obviously, if you want to get over a dog phobia, there's no way around it. You got to spend time with dogs. But if you do that, if you spend enough time with enough different dogs, eventually what it does is it retrains the brain that dogs are not dangerous, because it sees, this person's been with dogs for many different dogs, many different times for a long time, and they've not been physically harmed. And so, maybe we don't need the alarm bell anymore for this one. And so it shuts the alarm off in future instances of seeing a dog. So that's, it's a pretty straightforward concept ultimately. And really everything we do in exposure therapy, the point of it is to get their brain to learn that, get the brain to learn that the stuff it thinks is dangerous isn't really dangerous, and to learn that through the experience of being with the stuff. And so it's all just more and more complicated iterations of that process.
Mm-hmm. Yeah, it makes a lot of sense. And I'm thinking of a particular client as you're talking about that, who was terrified of dogs. And I happen to have a therapy dog here in my office with me. And for a long time, I couldn't bring my dog on those days because they would be so terrified that they, would just run out of the room and not be able to do that. But we gradually sort of, as you're describing, got her accustomed to that dog. And then she's able to sort of, who was just a complete marshmallow of a dog, right? So she was able to sort of then generalize that out to other dogs. But one of the things that's tricky about that is that, again, just like we were talking about with the pandemic, there is a legitimacy to that fear with some of those dogs who might not be so passive, and you could actually get hurt. So I would imagine you're up against that a lot of the time too, of distinguishing like what's legitimate, what's not legitimate.
So, and that, by the way, was a common thing even before COVID, that clients would often ask, because, the types of exposures we do for contamination OCD are things like, touching toilets and, touching public toilets, rubbing our hands on public toilets, eating off the bathroom floor, touching public door handles, playing around in the dumpster, rubbing trash on our faces.
How does that go over?
Yeah. I mean, people do get it, but the initial reaction is, of course, initially, oh, well, that's pretty disgusting. Couldn't I actually get sick from doing that?
Mm-hmm.
And the answer is, technically speaking, yes. The answer is yes, right? Because all exposures involve some uncertainty and some risk level. Mm-hmm. And that's kind of the point of it, is there's an overestimate of risk in the OCD. But so, if we do these exposures, if we touch all this gross stuff, there is a risk that you could get sick, but it will treat your OCD. And, I think the risk is extraordinarily small with the kinds of stuff we're doing. This is, not how most things spread. I've never had anybody get sick doing it. And, It's something we've done with a lot of clients before. And I know it sounds very strange, but is kind of standard of care for that type of OCD.
Mm-hmm.
And so if we do it, there's a small risk. Your brain says it's bigger than my brain says it is, but it's not zero, that you will get sick. However, the flip side of that is if we don't do the exposures, there is a guarantee, not a risk, but a guarantee you will have OCD for the rest of your life.
Mm-hmm.
Which one is really worse?
Mm-hmm.
And, so that's the thing that I think a lot of people miss at the start of therapy, that they kind of like realize as they really think about it, is the cost of OCD is pretty horrible. Like OCD sucks.
Yeah.
OCD is, really creates a lot of distress, a lot of functional impairment, really disrupts lives. It destroys relationships. OCD is awful. For most things that people are afraid of catching when they have contamination OCD, almost all the time, I would say I'd rather get the actual disease than have OCD. And so that's what we want to kind of adjust in that little risk equation there.
Yeah, that makes a lot of sense. You're weighing out it's sort of the lesser of two evils at that point.
Yeah, exactly. Right. COVID has shifted that,
Right.
During COVID, would we do stuff of the public toilet stuff? Early on, no. Now I think, again, there's like enough evidence that COVID doesn't really spread that way that again, I wouldn't be too worried about doing that. But we're not going to be doing things of like, go stand maskless in a crowded room of 100 unvaccinated people, right? Like that is how you catch COVID. And we're just not going to do that. So, you do still take reasonable steps to stay safe. It's just we're adjusting beyond the going too far that people with the contamination OCD do.
So if somebody has a contamination OCD and it's influenced by COVID or directly related to catching COVID, does that look like something more like going through what the research says about transmission, understanding what we know about it, and sort of going over that with them, reinforcing the fact that masks do work and vaccines work? What does that look like?
No. So this is an interesting part.
Okay.
It doesn't involve too much of that. They already know all that.
Okay, fair enough.
Most people have come in having researched all that part. So this is a little bit of where the exposure therapy has kind of updated over the years, is more modern. So the way of doing it is more of the kind of C part of CBT, the cognitive therapy part of CBT, where there's some kind of like rational disputation of the irrational OCD thoughts. And so the way more people used to do it, some people still do it this way, is you make kind of a thought record. You say, okay, here's the irrational thought. Here's the type of cognitive distortion, like the type of thinking error that's going on with that thought. And then here's the more rational kind of counter to that thought that you can use when that thought pops into your head. I think there are a few problems with it. One is they've done some what are called dismantling studies on exposure therapy and CBT in general for various different things. Not just OCD, but they'll do studies where they take apart the different components of CBT for OCD, and they compare effectiveness of the components alone versus together. And what they found is that adding the cognitive therapy component to the exposure component, which is the B part of the CBT, the behavioral part, doesn't actually add any effectiveness beyond what the exposure alone offers. And I think that the reason for that is that it's a little bit theoretically inconsistent with what we try to do in exposure therapy. So, exposure therapy is all about taking risks, right? It's all about uncertainty. OCD is all of it. The nickname for OCD is the doubting disease, because it's all about the anxiety being triggered by some kind of uncertainty. In the case of contamination, it's uncertainty about whether I'll get sick. And so what we want to do exposure to is not just touching stuff. What we're doing exposure to really is the uncertainty that you're going to get sick. And we really want people to experience that uncertainty very acutely. And so when people use little reassurances or reminders of, hey, remember, this is not really how COVID spreads. It's okay to touch stuff because this is not really how COVID spreads. That is a little bit of a way of doing kind of an in the moment short-term avoidance behavior, which serves the same function as the compulsions. And what we want to do is we don't want to run away from the dog. We want to confront the dog. We want to hold the dog really fully. I kind of liken it to, if you imagine you did exposure, if you had a dog phobia and you did exposure therapy to dogs, but you were wearing a full suit of body armor the whole time, what your brain learns is not this dog is safe. What your brain learns is body armor work.
Yeah, I need body armor.
Yeah, exactly. Right.
Yeah.
And so, that I think that traditional cognitive therapy component there, I think is a little bit like that. And it also is very much like a lot of compulsions that people do. So another compulsion that people do, even aside from hand washing and cleaning stuff, is reassurance seeking. So people will ask like loved ones, do you think this is okay? What should I do about this thing? They'll research stuff online. And the point of that is to try and rationally dispute the thoughts they know are irrational. People with OCD, 90% of people with OCD know that their thoughts are irrational. And they can have these more rational disputations. They've looked up information about it. Loved ones have told them, things are probably okay. It's just that, when they get that reassurance, they feel better for like 2 seconds. And then their mind comes back and says, well, sure, but how do you really know? Right. And that's the problem. It's that uncertainty. And that's what we really want to expose to. So that's kind of a long answer to your question, but that's why we don't typically do too much of here's what research says about COVID. Here's how the transmission happens. I will throw it in like just a little bit early on to say, here's why I'm willing to do this. I wouldn't ask you to do anything I actually think is dangerous, but all the research says touch and surfaces is not really how COVID spreads. So that's why I'm okay doing this. I'll say it once, but then we don't repeat it. We don't really dwell on it. We kind of go more with, let's feel uncertain about it. You don't really know. Who knows if I'm really right? And they do say it's technically possible to catch COVID from a surface. It's just really unlikely.
Right.
So there's still that uncertainty, and that's really what we want to be exposing to.
Huh. So how does that work then? I'm trying to like get an idea of, so say I come into your office and I'm like just debilitated by my fear of catching COVID and I don't want to leave the house. And what do you do in that situation? What does that look like?
Yeah. So in that situation, so what you'd be doing is gradually doing exposures with the person to going outside, going out of their house, touching things that they wouldn't normally touch. And then when they go home, allowing their home to be, what they perceive to be contaminated with the fact that they were outside, with anything they touched outside. So with contamination OCD, basically it's not that people can feel they can never touch things they perceive to be dirty or contaminated. It's that everything in the world exists in one of two states. Everything is either dirty or it's clean, and they don't want the two to ever mix. They don't want any of the clean stuff to ever get dirty. So you'll see people who do go out, but then when they come home, there has to be a lot of washing because they don't want to get anything at home contaminated, stuff like that. Yeah. So a lot of the process is not just touching the dirty stuff, but then after you've touched the dirty stuff, go home and touch all the stuff you perceive to be clean.
And then being able to tolerate that you feel like you've sort of contaminated the inside of your house, and you have to sort of be able to kind of sit with that. So
it's about willingness, right? So, the alternative approach, like the cognitive therapy approach, is what they call like a second wave behavioral therapy. And the newer third wave is more of like an acceptance-based approach. So we work with clients on, instead of trying to dispute thoughts or get rid of irrational thoughts, what we do is we work on accepting the thought, but changing your behavior in spite of the thought. So there's a lot of work around that, which, can involve like mindfulness work and just kind of talk about allowing emotion and having a different relationship to your thoughts and your emotions while changing your behavior.
Yeah. It sounds very much like distress tolerance, like being able to sort of sit with something that feels a little bit uncomfortable for some amount of time.
Right.
Can you tell me a little bit about, because I know you work with kids and adolescents, and tell me a bit about that and how the work is different, or maybe even not different, versus working with the adults.
Yeah, sure. So the work itself, in terms of like the actual exposures and like what's going to work to get someone over the OCD, is really the same between kids and adults. What's different is really kind of how we explain it. Like we might explain things in kind of easier to understand terms. The younger the kid is, we kind of refer to OCD. For younger kids, therapists will often refer to the OCD as like a bully. And the best thing to do with a bully is ignore them, not do what they're saying, not let them get to you. And so, that's how we want to treat the OCD. So kind of little explanations like that. With adults, we would give like a pretty detailed explanation of some of the brain science behind what's going on in your brain with anxiety and OCD, and how exposure therapy changes what's happening in your brain. With, I'd say, like 15 and up, we still give that. With younger kids, that it's probably a lot for them to catch on to. So we talk about it just more in simpler terms of like, what do we do when we're afraid of something? We face the fear. That's the thing we do. We don't listen to the OCD. We face the fear. Stuff like that.
Okay. And tell me about your work then with parents, because I imagine that's a big part of the picture as well.
Yes. Yeah, for sure. So how involved parents are with kid treatment of OCD depends on the kid's willingness to follow through on exposures on their own, and it depends on the parent's involvement in accommodation of OCD compulsion. So what I mean by that is a lot of parents, when their kid is anxious, I mean, the typical thing that most loving parents would do, of course, is try to help the kid calm down, right? So, but that starts to escalate and kind of go too far in a way that really helps the OCD rather than helps the kid. So what ends up happening is parents will help with compulsions. They'll help unintentionally with helping the kid avoid. So that happens through things like, the kid doesn't want to touch something and they ask the parents to pick it up for them. But the kid doesn't want to do laundry or, touch dirty laundry, so the parent has to do it for them. The parents have to do certain cleaning rituals before they make dinner to make sure that the food isn't contaminated. It can be a lot of stuff like that. It can also be, the most common one is reassurance seeking and answering reassurance seeking questions. So the kid will, like I mentioned before, ask, is this okay to do? Do you think I got contaminated with this? What about that thing? And parents will typically do, again, the normal human response to that is, no, it's okay, honey. Here's why. That's probably fine. I don't think you're going to get sick from that. I think you're going to be okay. And that sort of thing on the surface appears to be the good thing to do for your kid in that situation, but you're really helping the kid avoid the anxiety and avoid the uncertainty, which is exactly what keeps OCD going. So a lot of the work with parents first involves kind of training them up on how to respond differently when their kid comes to them with a request for accommodation of a compulsion like that. So it would be, if the kid asks you to do something for them that they would normally be doing themselves if they didn't have OCD, the answer has to be no. And then we teach them how to give, an empathic doing the actual compulsion. So, things like that. That part happens with most parents with kids with OCD. The part that depends more on the kid's willingness is, some kids are less willing than others to follow through on exposures. It's tough to do exposure therapy, right? It's a good news, bad news situation. Good news is it works great if you do it. Bad news is not a fun process. It does suck to do it.
Yeah.
And so, you got to go through the pain in the short term for the long-term gain. And some kids are not really willing to do that on their own. So we have to create more of a system of rewards and incentives and consequences for doing or not doing exposure therapy exercises. So basically that's up to parents to implement. So we teach parents, here's what we would do. We want the kid to get a reward for every day that they're doing their exposure exercises. And then, we do want there to be a consequence for not doing the exposure exercises, which usually involves things like taking away electronics and stuff like that.
Right. Yeah, it's difficult, I think, because you're asking, on the one hand, parents to go against, as you described, their natural loving inclination as parents to go in and to help and to soothe and all of those things. But also with the child themselves, they might not be able to grasp on to that concept that you're, obviously depending on how old they are, that you, as you were describing earlier, are doing these short-term things for those longer-term gains. If you're 8 years old or something, you're like, what are long-term gains? I don't know. Like we're just talking about like right now with my Nintendo. Like I don't understand.
Right. You'd be surprised actually. Kids do get the idea, the intellectual understanding of the idea. Your fears get better when you face them. Kids actually do get that pretty easily. Whether they're willing to do that or think it's important for their OCD to go away, that is maybe a different story with some kids.
So it's more sort of like whether or not that's dystonic to them or something that they see as an issue that they need to work on, which if you get potentially dragged into therapy by your parent who's like, we can't deal with this anymore, then you're up against that too, I suppose.
Exactly. That's where we do more of those systems. Is some kids come along willingly, other kids, yeah, you kind of got to drag them along, and sometimes it's dragging them along kicking and screaming. But if the OCD is bad enough and the parents are like, this has to be treated, that's kind of what has to happen. So the way we put it to kids sometimes is like, look, you're in that situation, if they're really unwilling, look, you're making a bad decision about your health here. Your mental health is part of your health. You're making a bad decision about your health. Sometimes your parents have to make the decision for you to make a good decision about your health.
Well, I'm curious also what you run up against in terms of like mischaracterizations in the media around OCD, or the sort of flippant way that some people will say, oh, I'm kind of OCD about this, which essentially just means that like I'm neat and I like things clean.
Exactly. There's a lot of that. I think there's not a good understanding in most media at all of what OCD actually is and how distressing and horrible it actually feels to have OCD. So most of the time you'll see like, people, there's a character in a TV show and with who has OCD, and that's their character quirk, and they like organize their pens really neatly on their desk, right? Like,
but everything else is okay.
Everything else is fine. Like that's not what most OCD looks like. That's that phrase like, oh, I'm a little OCD, or I'm so OCD. People with actual OCD kind of cringe when they hear that.
Yeah, I'm sure that's true. I thought it was interesting as well, and in reading about the way that you work with exposure therapy, and one of the sort of questions you had on your website was like, how long does it take in terms of sessions for this to resolve itself? And you give a pretty quick timeline of, I think it was 5 to 20 sessions or something like that. And what do you say to people who are in, because I think there's, sometimes there are these like therapeutic modality camps, right? Of the more like CBT kind of approach that you're describing versus therapy is a relationship-based process, and it, is within the relationship, the transference and countertransfer, that kind of psychodynamic perspective, like that's where the curative factors are. What are your thoughts about that?
Yeah, so I as you would imagine from how I'm talking, fall very much into the CBT camp with a heavy emphasis on the B, and very much not a psychodynamic person. So we get a lot of, I would say it must be probably 70-80% of people that we treat with OCD at our practice have been to another therapist before and had therapy not work. And almost always it is kind of like a generalist practitioner who either kind of has an eclectic approach or does more of that kind of traditional psychodynamic approach. And it just does not really work with OCD. And there's not research support for it with OCD, whereas CBT has like decades of research support for CBT and exposure therapy specifically, being the gold standard of care. So my stance is also, even for other problems besides OCD, like there's just so much evidence therapy just does not have to take that long for most things. Now there are exceptions, right? We do have clients who see us for years who came in with really severe OCD, or where willingness was low, and they do things really gradually. That's totally fine. Nothing wrong with that at all if the person needs it. It's just that, most people, it does not have to be that way.
So if it does take longer than that, you see that as being, I suppose, like I don't want to just characterize it this way, but like motivation plays a factor in that, in terms of the client's own willingness to really engage with the process.
Typically, yes. So the biggest factor of speed of therapy is, I would say, overwhelmingly client willingness to do exposures and the pace that they choose for the exposures. And so, there's kind of two schools of thought about the pace of exposures. There's one school says, we should do what's called the flooding approach, which is we don't graduate the exposures. We just do all the hard stuff right away and get it over with as fast as we can. Another school is, the more graduated approach, which is, we start with easier exposure exercises and then gradually work our way up to the hardest stuff. And my take is both are fine. It really just depends on what the client is willing to do. the flooding approach is great and it gets a really fast treatment for people that are willing to do it. It's just that, many clients are not willing to do it. So you can't do it.
Right.
You can't do something the client's not willing to do. And so, you do the graduated approach, and then clients vary in how slowly they want to graduate things.
So you have to sort of meet them where they are in that way with how much they're willing to tolerate. Right. Yeah. Makes sense.
Exactly. Yeah. And so to answer your question more directly, it's like for the longer term people, like why is it taking longer? So I'd say one of two reasons. The reason is, typically that willingness reason, that they want to go a lot more slowly, or that they know they need help, but the buy-in for doing therapy, the buy-in for doing hard things that exposure therapy requires is not really fully there. And so a lot of therapy can be kind of, discussion about commitment to the process and discussion about the reasons to do it. And like, what are the hooks for them that get them to do it? That can just take longer. But there are some cases where the reason it takes a long time is just the breadth of the OCD, like really severe case, even with a very willing client. It's pretty severe, and there's a lot of different themes to the OCD, and it just takes a while to get to all of them. That can sometimes be the case too.
Mm-hmm. Mm-hmm. Is it ever the case that the person maybe has conflicting feelings about getting better and what that will look like? Will they be a different person?
Oh yeah,
and I would imagine that would get thrown.
Yeah, absolutely.
Well. Yeah.
Absolutely. I would say that the different person one, we do see some people say that's the less common. It's more often just perceive the risk of doing the types of things we do for exposures as too risky and not worth it. So, if people are like in that example of contamination OCD, if they really believe they're going to get sick and really, really averse to getting sick, their kind of risk assessment equation falls more on the side of it's worth it to me to avoid the risk of getting sick, even with these impacts it's having on my life. And so that often experiential avoidance, like people are just really intolerant of the feeling of anxiety. People differ in that distress tolerance that you mentioned before. Like some people are like, okay, I'm willing to feel anxious in the short term in the service of my values of getting better and regaining the things this is impairing in my life. Other people, that's less of a hook for them, and that the feeling of the anxiety is so bad and so distressing to them and so intolerable to them that it doesn't feel worth it.
It's interesting because in the society that we live in, I think a lot of people are looking for that quick, short-term life hack or something, right? Where you're like, I just want to feel better right now. I can't deal with this. I just give me something to help me to feel better with
Totally.
this. But the irony is that there is something for this, especially when we're talking about OCD. But the thing that you have to do, even though it will be relatively quick, especially in terms of when you're talking about mental health, I mean, that's really quick to go through that many sessions and to feel better that quickly. But the thing you have to do is fundamentally uncomfortable so that there's aversion to that. You know what I mean? Yeah, that's interesting.
Absolutely. Absolutely. And people, especially with that poor distress tolerance, they're looking for that magic bullet.
Right.
And the thing with anxiety is the more you want anxiety to go away and the harder you fight anxiety, the more of it you get. So it doesn't really work that way.
Right. You're feeding it. Yeah.
Yeah, exactly. Right.
What would you say to maybe a parent who's listening to this and they're just wondering about what to do and they have their child that's struggling with OCD and anxiety? What would you say to that person? And is there any kind of a takeaway message that you would want for them to have?
Yeah, definitely. I think two big things I would say. Number one is you want to model an accepting attitude towards anxiety. And you want to kind of separate the emotion from the behavior. What I mean by that is it's totally okay to feel anxious. Anxiety is not going to hurt you. You did a good job for feeling that feeling. I'm proud of you for feeling that feeling. Really model for them, everybody gets anxious sometimes. It's okay to feel anxious, but we want to work on changing the anxious behaviors. And so for parents, kind of modeling that acceptance, but encouraging change in behavior, not accommodating avoidance of anxiety, not helping the kid feel better short term, but more like expressing that, it's okay to feel this way. I'm glad you're feeling this way. This might be what you need, like that kind of attitude towards it. That's, a better way to approach it at home. And then, the other big thing is, like you said, we have really good treatments for all types of anxiety disorders and all types of OCD. There's stuff that works really well for it. And so if it's to the point that it's really impairing the kid's life, get help. Help is available, and it's become more and more readily available in more and more parts of the country over the last 10 years. Back when I started my practice, it was really hard to find specialized help for anxiety and OCD, and it's gotten easier. There are more and more therapists that are familiar with this, more and more therapists that are trained in it. So find specialized help.
So differentiate between the feeling of anxiety itself and the behaviors that come with it, and also know that there's help and that there's hope out there.
Right.
That sounds great. Well, thank you, Dr. Stein, so much for joining us today. I really appreciate all your insights, and hopefully there'll be some folks out there who hear this and it'll be helpful for them.
My pleasure. Thanks for having me on.
Sure thing. All right, that was Dr. Michael Stein. His website is anxietysolutionsofdenver.com. If you're lucky enough to live in Colorado or Nevada, you can actually go and schedule an appointment there. So that's it for today. Until next time, be well and be in touch.
This podcast is not intended as medical or psychological treatment. In no way should it replace treatment from a mental health professional.